general circulation, hypoxemia. So they call it not hypotension, they call it compromised circulation. And using of antihypotensive is also very controversial. Like this article published in Pediatrics 2013 and said using of antihypotensive was not associated with improving hospital outcome. Another publication from Archive 2015 showing that even it caused more worsening in outcome in Kennedy network in US. But in Paris, they published another study saying it's improving outcome of using of antihypotensive. And most of the people, they are thinking about dopamine, dopamine, most of researchers were there. So first we need to know the other things like NOR-EP and vasopressin, if they are safe. Yes, they are safe, but the problem also is the population. It's retrospective study, 30 babies after 8 hours. So yes, we can use it, but we couldn't say this is evidence-based approach. Even vasopressin showing in this study that it's better than dopamine as a randomized controlled trial, but also the population is 20 days, so very small population. And even here another study from Mount Sinai in Canada, and they said in retrospective, which also low degree of evidence, showing that NOR-EP is better than dopamine for septic shock relief. And I was very excited to know the result of this study when they started to do it in 2017, which called the HIP trial. So it was a very huge centers, 10 US, 10 North American and European centers with a good population and good study design. But what happened, it was terminated early and they recruited only 7%, so they didn't get any result from this HIP trial. Also, Cochrane didn't give us, as usual, any answer for this topic. So even it was started of using physiological-based approach, till now, a new review showing it's the same dilemma. So for the last 7 years, there is no changes in this topic to be using antihypotensive medication as evidence-based. And the most popular, widely used tool is using a pathophysiological approach. So why we are using pathophysiological approach? Because high level of evidence is lacking, and we are using the selecting approach according to pathophysiology of the disease causing hemodynamic compromise, and at the same point understanding the pharmacological effect of the medication. As we see here, even with decreased cardiac output, the babies might be normotensive, and these babies, you say you didn't give them anything, they will go from compromised circulation to irreversible shock without getting anything. The most common scenario used in pathophysiological approach is vasodilator scenario. When the babies have sepsis, SIRS, NIC, this is the most common scenario in our unit, seeing the babies decompromised, and the pathophysiological approach is giving them vasopressor, not giving them inotropic medication. And as we see, septic shock could be cold shock, but it's very rare. Like in the last 7 years, I saw one case and hundreds of cases with vasodilator shock in ICU. Something like HIE and post PDA ligation, you are dealing with different category. You need inotropes, and according to the diastolic or systolic functional impairment, you will give the appropriate inotropes. Hypertrophic cardiomyopathy in IDM is another scenario. Arrhythmia usually more challenging. So what we are dealing with low cardiac output status and low systemic vascular resistance status. And usually low cardiac output status either to reduce the preload or increase the afterload or reduce contractility. In case of low vascular resistance status, which is vasodilatation or increased vascular bed, like hemodynamically significant PDA, as well as hypovolemia. And we need to target our medication according to understanding of each disease pathophysiology. And when we look here, we shouldn't wait till anaerobic metabolism or decreased oxygen consumption, which is irreversible shock. We should treat the babies early. Usually I'm saying to the resident, we need, don't be in reaction to what the baby, be proactive. So if we are proactive in using vasopressor and inotropes, really the result will be different. So when we are looking to clinical indicators, a lot of clinical indicators is different from like scenario to another, but what I'm looking here to systolic hypotension and diastolic hypotension. So please don't rely on MAB, which is the most commonly used way of relying of hypotension and treating medication. Low diastolic blood pressure means decreased systemic vascular resistance, and you need to give vasopressor even if you have normal MAB. And the same, diastolic hypotension, you might have diastolic hypotension with normal MAB in cases like HIE or anything causing vasoconstriction of the vessels with low cardiac contractility. And a lot of modalities we can use to assess the systemic vascular circulation, like echo, bioimpedance, NIRS, and pulsatility index, as well as integrated EEG. So looking to the most common used drugs, something like dopamine. I hate dopamine. Dopamine is working in everything. So this kind of medication, what you are treating, and that's why in a lot of research they found that dopamine didn't increase cardiac output because it's contradictory to what you are treating. At the same moment, if you look to vasopressin, it's only working in one receptor, so it's a vasopressor only. So dopamine, as we know, it's a different action according to different doses. And when we look here, the doses is different in preemies. Usually in preemies, you can get a vasopressor action in a very low dose, 2 to 4. And usually because the dopamine most commonly medication, if you get effect on 4, don't keep going increasing dopamine. Try another vasopressor medication, either norepi or vasopressin. Because dopamine had unpredictable effect in newborn, and 25% will transform to norepi, so by the time the effect will decrease, and the dose of 6 to 8 either decrease or increase cardiac output. So which one will happen with you? Nobody will know. And metabolism and decrease in breath air and high doses might cause arrhythmia in preemies. Dopamine might be a better drug, like in the case of poor contractility, but don't give dopamine a baby who has hypotensive, especially higher dose of dopamine, because higher dose of dopamine, as you know, this will cause vasodilator, and the baby will be more hypotensive if you are using dopamine high doses. So it's mainly inotropic effect. Tachycardia is this, and minimal impact of peripheral circulation in low doses, but high doses can cause vasoconstriction, and it is more effective, increases systemic blood flow, but it might decrease also pulmonary vascular resistance. So in case of pulmonary hypertension, it might be useful of using dopamine. Epinephrine, it's a strong beta and alpha receptor, and increasing both stroke volume, cardiac output, systemic vascular resistance. But the problem with epinephrine, it had a lot of side effects, increased lactate, increased glucose, and metabolic acidosis, and the effect of coronaries is very controversial. So it increased the metabolism for the heart and might cause myocardial ischemia. Norepi, the people start to use it, especially in septic shock or vasodilator shock, even in neonate. And the usual started dose is 0.1. It might go to maximum 0.3. And with experience of using NOR-AB, you might go beyond this 0.3. You can go to 0.7, 0.8 till you get the effect. The problem is that if you get high in NOR-AB, that might develop tachycardia, and tachycardia decreasing the stroke volume, there is no relaxation time. But why we are not using vasopressin? Why a lot of neonatologists prefer to use NOR-AB? It's a technical pharmacological issue. The preparation of vasopressin is very tricky. It's a very low dose, and you need to have pharmacists, they really know what is the dose of NOR-AB, of vasopressin, and use it. But if you have appropriate clinical pharmacist, might be vasopressin will be used as a first line for vasodilator shock, because it's effective and can work with acidosis, never cause tachycardia. Merinone, it's a perfect drug as inotropic drug, and lusitropy with reduction of both systemic and pulmonary vascular resistance. The main issue of merinone, don't give merinone in diastolic hypotensive baby. It might cause a severe diastolic hypotension. And this is a very important, and no antidote for merinone. It metabolizes in liver and takes time. So merinone, it's a first choice in a lot of babies in HIE, BBHN, and post-PDA ligation, but you should have a good continuous monitoring of diastolic blood pressure. And don't give a bolus, even it's written in a lot of new facts and the other to give bolus. Don't give bolus in merinone, especially in preemies. Hydrocortisone, it's usually a good medication to give in resistance, especially a lot of preemies, they have suprarenal dysfunction, and it is really, it's a good drug to start in resistant hypotensive, because it's increased expression of adrenal receptors, increased circulating choline, stimulate conversion of AB to NOR-AB, inhibits vasodilators release, and can be used for postnatal adrenal insufficiency, and the usual dose is 2 milligram per kg loading, then maintenance to either in 2 or 4 doses. And as we mentioned, this is a collection of all drugs that are mainly effective in increasing systemic vascular resistance in NOR-AB and vasopressin, but merinone decrease systemic vascular resistance and decrease pulmonary vascular resistance, but this is improving stroke volume. So this is also summary of the agent. I will not go through it with those ranges. I'm asking you to use this kind of table. Don't use MAB less than gestational age. Use this kind of table to know the historic hypotension, the pulse pressure of the babies, and which one you need to target. So our suggested approach, like this is even McMarra's suggested approach, not mine. So in BDA, the first line to decrease shunt volume, either to decrease shunt volume with increasing pulmonary vascular resistance by high beam or giving medication. But also you need to show if this is affect in the organ or not. If there is effect in the organ and you don't have low diastolic blood pressure, dobutamine will be your first choice. In post-PDA ligation, the first choice, and even some people is doing merinone prophylaxis, and it's controversy. I like to start merinone prophylaxis and lasers in this babies, but some people they didn't like it, and it's controversy in research. But dobutamine and merinone will be your first choice, and if resistant, please don't forget hydrocortisone in post-PDA ligation syndrome. Sepsis, usually it's warm shock with low diastolic blood pressure, and even be sure that you are not giving enough volume, especially in the first days on preemies, and using vasopressor, NOR-AB, and vasopressin as a first choice. And if you are query, you can give starting by low dose of dopamine if it's difficult to make as a first choice, as the people not very familiar with it, and they think that you need to start dopamine. So start dopamine with low dose, but don't delay nor AB or vasopressin. In case of hypoxic ischemic encephalopathy, as we mentioned, you need to go to the physiology. The hypoxic ischemic encephalopathy, mostly contractility is affected. So you need to give something that improves contractility. So if the contractility is affecting, dobutamine will be your first choice. But if the baby is, and might be known if you have normal diastolic blood pressure. But if you have low diastolic blood pressure and you need to give something to improve both systemic vascular resistance and contractility, then epinephrine will be your choice. Persistent pulmonary hypertension, so almost the same, very known, you can use it, but be sure the baby is not hypotensive. If hypotensive, vasopressin can decrease pulmonary vascular resistance, so you can start with vasopressin, giving dobutamine, which is lower hypotensive medication, added to vasopressin might be your first choice. Infant of diabetic mother, usually we are not loving to give inotropes of infant of diabetic mother, but you can give something like vasopressin and giving a little bit increase the volume. So in summary, there is no strong evidence of evidence-based medicine in management of compromised circulation. Heterogeneity of the babies and physiology is high. Using history, detailed cardiovascular diameter using both systolic and diastolic. If we got from this lecture just using systolic and diastolic blood pressure, this will be enough. And physiology-based individualized approach will be might be the best choice if we have enough resources using echo, NIRS, integrated EEG might be helpful, and understanding the physiology and pharmacological effect of CNS support drugs is crucial. Thank you.